Good evening, everyone. Today we're gonna come to present Mr. RT case. Mr. RT is 56 years old, gentleman, presented with the symptoms of depression. The history of present illness. Mr. RT, a 56 years old gentleman who is known to have a COPD, a previous ST elevated myocardial infarction, treated with PCI, represented to the clinic complaining depressed mood consistently in the last 6 months. Had lost interest in his hobbies, constant feeling of guilt, fatigue, and worthlessness. Had lost ability to concentrate at work. Symptoms got worse with winter season, cold weather, holidays. He has no suicidal ideation, no bipolar, mania, anxiety, or insomnia. Mr. RT first attack of depression was back in 2017 after a PCI standing post-ST elevated myocardial infarction. Tried citalopram, worked well, but it caused him sexual dysfunction and diarrhea. For his COPD, last exacerbation was March last year, no bronchitis, but he still has symptoms of SOB while walking or exercising. On exam, vital signs with normal values, his body mass index 25.1, labs finding, his HbA1c was 6.3, his forced expiratory volume 60%, his forced expiratory volume by the functional vital capacity is 0.6 and QT is 457. So now we'll talk about his past medical history. Mr. RT is an overweight, has a dyslipidemia, suffered from ST elevated myocardial infarction 3 years back, treated with PCI. He has a COPD and he's an active smoker, occasional alcohol drinker, increased in the last 2 weeks. His medication, Mr. RT is on metoprolol succinate 50 milligram daily, fluticasone 100 microgram twice daily, albuterol 2 puffs every 4 hours PRN for shortness of breath, atorvastatin 80 milligram daily, aspirin 325 milligram daily, and his vaccination profile. He has vaccinated against the influenza last year, March 2018. To prioritize his problem list, according to his complaint, depression was his major and primary complaint, COPD, which is current problem, smoking and obesity is a secondary complaint. Now we're going to talk about depression. The assessment. Mr. RT presented with 5 symptoms out of 9 of depression, including loss of interest and consistent depressed mood for the last 6 months. According to the DSM-5, it is a major depressive disorder. And according to the HAM-D scale, score 16, it's a moderately severe depression. Patient had tried citalopram 3 years ago, achieved improvement, but caused unpleasant erectile dysfunction and diarrhea. Many factors that might be contributing to the depression being a metoprolol, his medications, having symptoms of COPD can also worsen the low mood, and the goal of treatment to achieve a good response to medication measured by 50% improvement of symptoms in 2 to 4 weeks, achieving remission in 10 to 12 weeks of initiating treatment, and to reduce his HAM-D score to be less than 7 and screen for suicidal ideation. Recommendations. So for non-pharmacological measurement, educating the patient about the importance of medication adherence, calling the doctor for the presence of the side effect, mainly suicidal ideations, allow 2 to 4 weeks of medication to work, and also to treat with psychotherapy, cognitive behavioral therapy, or interpersonal therapy would be recommended. Rationale of that, based on a literature review, that met the IOM and MSTAR requirements. A group with a CBT and life review based intervention were the only intervention with adequate efficacy evidence. It also showed effectiveness in several meta-analyses was done on 6,900 patients compared to CBT with controlled condition. So remission occurred in more patients treated with psychotherapy compared with controls. Live therapy, 10,000 lux intensity, slanted toward the face of the patients for 30 minutes, preferably in the morning, as patients stated that symptoms were worse during the cold weather and the holidays might be effective. Combining psychotherapy and pharmacotherapy is more effective according to the APA guidelines. Pharmacotherapy, there is no studies that shows any of the antidepressant medications is superior on the other options. Patients is requesting medication that does not cause any of the GI or sexual dysfunction symptoms. Accordingly, bupropion is a good choice, as it is the least among the antidepressant to cause sexual dysfunction and GI symptoms. It is also the first line of treatment in patients with major depressive disorder who are willing to quit smoking as well. Recommended lengths of treatment is from 6 to 12 weeks. Meta-analysis of patients, data from 37 randomized controlled trial. Number of patients was 8,400 patients with major depressive disorder compared to patients with major depressive disorder on venlafaxine or fluoxetine with placebo for 6 weeks. Remission occurred were received active than placebo. So that give us kind of an insight that medication would definitely be beneficial to Mr. RT. Monitoring, symptoms improvement in 2 weeks. If no improvement after 4 weeks, consider treatment switch. Bupropion can increase the exposure to metoprolol, so close observation for hypotension, bradycardia. If any of the symptoms occurred, consider adjusting metoprolol dosage or switch to bisoprolol after consulting the patient's cardiologist. For the COPD assessment, last exacerbation was last March 2019. No history of hospitalization, frequent symptoms such as shortness of breath while walking or exercising. Patient is still active smoker, 1 pack per day. His forced expiratory volume is reduced 60%. His forced expiratory volume compared to functional vital capacity ratio is 0.63 and was reduced. CAT score is 23, above 10. According to the GOLD guidelines 2020, patients lies under the GOLD 2 group. Assessment of the treatment plan. Patient is currently in short-acting beta-agonist inhaler, allopurinol, and inhaled corticosteroid. According to GOLD, this is not an appropriate treatment for Group B GOLD patients. Treatment plan should be changed. Accordingly, goal of treatment, decrease or eliminate breathlessness and improve exercise tolerance, prevent COPD exacerbation or hospitalization, and improve quality of life. So recommendations: first, discontinue fluticasone, keep the short-acting beta-agonist inhaler for PRN, for acute attack of shortness of breath. However, with an appropriate treatment, its use should be minimal. Start long-acting beta blocker, formoterol fumarate, 12 microgram per capsule, 1 capsule inhaled PID, a maximum of 48 microgram per capsule, as 2 capsules inhaled PID. The rationale, according to the GOLD guidelines for Group B, monotherapy of long-acting bronchodilator is recommended with escalation of dual therapy if symptoms persist. Smoking cessation is a key for symptoms improvement. According to GOLD guidelines, smoking cessation can decrease the incidence of acute exacerbation of COPD. The doctor in this case wanted to consider nicotine therapy. However, it might not be the most appropriate option as nicotine might exacerbate the depression and suicidal ideation. It also has a negative effect on the cardiac health. Considering non-nicotinic option would be a better option for Mr. RT. At least 3 minutes counseling from a healthcare provider about quit smoking can increase his chance to quit smoking. 5. Encourage the physical activity to reduce the risk of immobility. And also, according to the GOLD guidelines, vaccination should be taken annually. Last vaccination was taken 2018, which means that it's due to another influenza and pneumococcal vaccines. And especially that is recommended for patients over 65 years old with comorbidity like heart disease and lung disease. A moderate quality evidence suggests that vaccination decreased the COPD exacerbation. Evidence B. Monitor symptoms improvement. Medication side effects such as tremor, nervousness, hyperkalemia, checking serum potassium serum always, tachycardia and palpitation that may be symptoms accompanying with the medication. In general, the patient is a week from the initiation. After a week of, usually the monitor is after a week of initiation of the treatment, assess the effectiveness of the treatment plan, breathing symptoms, suicidal ideation, blood pressure, and viral symptoms. Thank you.